Hello, friends. Welcome again. Now, friends, today we are going to do the fourth video on the vital pulp therapy, and this video is having some added information for all of you. Now, friends, we all of us know that when we talk about vital pulp therapy, we are basically dealing with four types of procedures. One is the indirect pulp capping, then the direct pulp capping, the partial pulpotomy, and the full pulpotomy. I think that is where uh, commonly we are classifying the various uh, pulp preservation procedures, you can say, or vital pulp therapy procedures, you can say, are ending now. In the previous from the previous two editions of the latest textbooks, like from the 11th edition of Cohen and obviously the present edition also, we have this another added very important dimension to the pulp therapy procedures, and that is deep pulpotomy. Now, what is deep pulpotomy? So, friends, just before that, let us just get the things into perspective. Let us just revise or review whatever we have done till now in the previous three videos and whatever we have learned. All right. So, when we deal with the vital pulp therapy procedures, we are dealing with four types. First is the indirect pulp cap. So, as this is very obvious from the terminology, the indirect pulp cap, that is when the caries exposure has not, while you're excavating the caries, you've not exposed the pulp. There is still remaining dentine thickness, albeit very thin, like 0.5 mm, but there is a definite barrier that is existing between our infected dentine and the pulp tissue proper. All right. And we would want to cap it. Historically, we've been doing it with calcium hydroxide. Presently, we have better materials like calcium silicate based cements, in which MTA leads the way, right? It's a time tested material now. Then we have a situation in which we are excavating deep caries and we enter the pulp. All right. So, carious exposure with pulpal exposure, right? So, that is carious exposed pulp. That is what we commonly say, a cariously exposed pulp. That is one situation. The second situation is the caries is not deep, but while doing cavity preparation, there is an iatrogenic exposure. Now, classically, so the second would be the direct pulp cap. Now, classically, the only indication of a direct pulp cap was iatrogenic exposure, especially when 2 to 3 conditions were met. That is, the tooth, there is only a pinpoint exposure. That's number one, only a pinpoint exposure. Number two, the bleeding could be controlled. Obviously, that is very important for all types of pulp therapy procedures. And number three was that you had the exposure of the pulp was well isolated from the saliva. So you were preferably doing the procedure under rubber dam isolation. Apart from that, the pulp was healthy, no signs of pulpal degeneration or, periapical pathology, no signs of periapical pathology, etc. All right, that is a situation in which you could do a direct pulp cap. However, presently, even in a cariously exposed tooth, now listen to this very carefully, even in a carious exposure of a tooth, of a pulp, wherein the pulp is either asymptomatic, right? Is either asymptomatic, or there are very minor symptoms of reversible pulpitis, right? Even now, if you are able to control the bleeding, then the latest textbooks, the latest Cohen 11th edition onward says that because of the presence and the practical use of the newer calcium silicate based cements like MTA, you can predictably do up to, with a success rate of up to 93, 94, 95%, you can do a direct pulp cap. But yes, the pulp should not be irreversibly inflamed, definitely. And you should be able to control the bleeding of the pulp by either pressure pack with saline dipped cotton pellets, or using 5.25, rinsing the pulp with the 5.25% sodium hypochlorite for a period of 1 to 10 minutes. Okay. And then replenishing it. If you're doing it till 10 minutes, replenishing it after every 3 to 4 minutes. Okay. So that's the concept, that it's like there is an expanded indication of a direct pulp cap procedure because of better calcium silicate based cements, which are now available to the clinician. Okay, fine. Then what is next? The next things are what we've already discussed, that is your partial pulpotomy, or which is also known as SWEC pulpotomy. We have discussed this in context with dental traumatology. All right. But again, you can do this in carious exposures of the pulp, preferably wherein the pulp is either asymptomatic or there are only minor symptoms of reversible pulpitis. Okay. Now, this is normally done, when you are dealing with, again, in cases which are open apex, immature, permanent teeth, wherein the clinician is desperate. He has to take a desperate measure to maintain the vitality of the pulp, so that apexogenesis or natural root end formation does take place. You want to preserve the formative capacity of the pulp. You want to preserve the pulp. All right. However, a better treatment for a carious exposure of the pulp in an immature permanent tooth would be a full pulpotomy. Why? Because, after carious exposure, there are more chances that the inflammation is deeper, right? So you can do a partial pulpotomy, but you have to ensure that there is only reversible pulpitis, right? And you are obviously able to control the bleeding after removing the superficial 2 to 3 millimeters of the pulp. All right. In a full pulpotomy, which is obviously much better for a cariously exposed tooth with, again, obviously, an immature apex. All right. Why do I keep reminding you of the immature apex? If the apex is mature, then there is no point in preserving the pulp here. Okay. You might as well do a root canal treatment, do a pulpectomy, and the predictability of the treatment is very good. Now, these are the 4 things which we know. Now, what is that 5th dimension? What is that 5th type of pulpotomy that most of us do not know? That 5th type of pulpotomy is deep pulpotomy. Now, when this is done and in which situation? You have a case of, again, immature permanent tooth. You are desperate to retain or to preserve the healthy apical pulp stump so as to retain the formative capacity of the pulp, so that root end maturation and root end formation does take place naturally. However, the problem is that the patient has come with symptoms of irreversible pulpitis. Now, in a case of mature tooth, irreversible pulpitis, you would not think twice. You would do a pulpectomy, do a root canal treatment, finished. But here, as I said, we are dealing with a case which is that of open apex. Now, yeah. So we have this open apex case. The apex is blunderbuss. It's also known as blunderbuss canal. It's an immature tooth, and despite the fact that we are, that We are taking that chance that the irreversible pulpitis of even the middle third or probably the apical third of the root canal will be there. The pulp would be irreversibly inflamed. We are still taking that chance to preserve the vitality of the tooth so that root and maturation does take place, as you can see in this diagram here. If this process of deep pulpotomy is successful, you have a nice, closure of the, development of a nice natural apical constriction, as well as increase in thickness of the dentinal walls. So what is the clinical procedure? I mean, in cervical pulpotomy, you would stop at the root canal orifice. Now, how are you supposed to do, predictably go deeper inside the canal and remove and amputate or resect the pulp up to some distance inside the canal? So how do you do that? Now, for a single rooted tooth, I'll just put the pen here. I'll select the pen. Yeah. Now, for a single rooted tooth, like this one as shown in the diagram here, simply use an endodontic spoon excavator or a round burr. Go some distance inside the canal. But what about a molar or a multi-rooted tooth? For a multi-rooted tooth, you can use simply an endodontic file or reamer. Okay, and go to some distance inside the canal. Again, use your normal methods of either saline cotton pellet packs, pressure packs, or sodium hypochlorite up to 5.25 to 6% for a period of 1 to 10 minutes to control bleeding. However, even if that is not successful, what does that mean? That means even the deeper layers are irreversibly inflamed, but you still take a chance. The clinician is supposed to be desperate to maintain the vitality of the apical pulp and just hope against hope. Just hope, pray that the apical pulp stump remains healthy. It is healthy and we are preserving that. So you can actually, Cohen writes that you can actually go to the extent of controlling the bleeding by hemostatic agents like aluminum chloride and ferric sulfate. So do that. Now this is what is deep pulpotomy. That you go inside the canal, try to preserve only the apical pulp stump and hope that it is still healthy and not irreversibly inflamed, and go to the extent of using hemostatic agents to control the bleeding inside the canal if you're not able to do it with saline or hypochlorite. So friends, this was about what I say the fifth type of vital pulp therapy known as deep pulpotomy. All right. Thank you for listening and watching, and happy studying. Keep working hard. Thank you. Best wishes.